So, first of all, thank you very much, Anishal, for the kind invitation. When I got the responsibility, I thought I am a little bit stressed. I am with the stalwart Patrick Kamath sir session, but now I am realizing that I am poor chap sandwiched between two stalwarts. Arun Sanil sir has given his deliberation, and next is Patrick Kamath sir. So my responsibility is to discuss predicting CHPS and varices needing treatment in compensated advanced chronic liver disease. So to discuss it, let's see what we used to see in everyday clinic, this common scenario, 43-year gentleman, non-specific abdominal discomfort, an imaging fatty liver, is a teetotaler, normal BMI, non-diabetic, non-hypertensive, having dyslipidemia. We leveled them as NFLD after thorough evaluation, LSM is 7, advised lifestyle modification and diet reduction. So he again presented 5 years later to OPD having mild right upper quadrant discomfort, imaging fatty liver, mild hepatosplenomegaly, LSM 17, platelet 2 lakhs. Patient says he adhered to lifestyle modification but could not come because of some work at Gulf, on scopy, dilated veins, early varices, so started non-selective beta blocker and atorvastatin for dyslipidemia. Patient presented 8 months later with hematemesis and melena, on scopy large varices, EVL done, mild ascites on ultrasound, LSM 29, platelet reduced to 1 lakh. So what did we miss? So is there any predictor? So we can predict you are going to bleed or something. So to address this, this is the outline where I will discuss few definitions, terminology, why to measure this, and methods to measure, principle of prediction, reliability, and key take. So this new terminology, cACLD, come to exist in Bevan's 6th in 2015. This is a compensated advanced chronic liver disease which reflect the continuum of severe fibrosis and cirrhosis in patients with ongoing chronic liver disease. So having HbPG more than 5, up to 10 it's mild portal hypertension, 10 or beyond is clinically significant portal hypertension. 2021 Bevan 7 tell cACLD and compensated cirrhosis are acceptable term, but they are not interchangeable. So they, with using liver stiffness, if it is less than 10, we can rule out cACLD. 10 to 15 suggestive of cACLD, and more than 15 is highly suggestive of cACLD. So what is CHPS? It is clinically significant portal hypertension, where HbPG is greater than or equal to 10. So why this terminology comes? Because CHPS is an important predictor which is associated with features of decompensation, which is variceal hemorrhage, ascites and HE, reduced tolerance in liver resection for SCC and death. So basically it is an important predictor. And what is varices needing treatment? These are large varices or any varices with red color sign, any size gastric varices or any varices with child C cirrhosis. So if we will see the natural history of CLD, so they have a very long compensated phase, having mild portal hypertension, and HbPG when it is more than 10, that is CHPS, which may have varices. When more than 10, they decompensate with ascites and HE, more than 12 HbPG, variceal hemorrhage, later further decompensation and death. So what is the aim of therapy? We have to prevent CHPS, prevent decompensation and prevent further decompensation. So why this CHPS is so much important? So basically if you'll see this is an important predictor of decompensation. If you'll see the natural history, compensated patient have a median survival of 12 years, whereas decompensated patient have 2 years only. Again 1 year mortality rate in compensated patient 5%, and decompensated it is 20%. So it is very important predictor, CHPS is. So if we know this early, there is early initiation of treatment we can suggest, like NSBB and other thing. So what are the method to know this CHPS? There are few invasive methods, there are few non-invasive methods. So this HVPG is considered as gold standard or reference standard, but there are some issue with HVPG like affordability, cost is a issue, accessibility. Our little few centers are there in India who can do HVPG on regular basis, expertise required, it is not a point of care, and minimal risks of complications are there. US can measure portal pressure measurement, however cost, sedation, learning curve and risks are few issues. So let's see what are the available non-invasive methods which can predict CHPS. Of course, sign and symptoms are there, few serum-based tests are there, and there are some imaging, ultrasound, CT, MRI, elastography like liver and splenic stiffness are there to predict CHPS. So physical sign we already know, ascites, splenomegaly, spider nevi, this photosystemic collaterals, pedal edema, pleural effusion. So these are there which can, if patient is decompensated, there must be CHPS. These clinical signs and symptoms are there. So what laboratory tests or serum based markers are there? So these serum based markers are easy, applicability, reproducibility, and it is available. But thing is that individual component of a serum marker can be affected by comorbidities. So their diagnostic accuracy alone as a marker or predictor are always modest. And this none has been validated to monitor HVPG changes with or without treatment. So in clinical each one is limited. So what are the markers? Low platelet count, albumin, P4 and von Willebrand factor, vitro score, new vitro score is there, and there are a lot of serum based markers are there. AST to platelet ratio, AST to LT ratio, fibro, FON, log index. So lot of markers are there. So let's see what are imaging. Imaging what it does? Ultrasound, CT, MRI, they depicts macroscopic changes in liver, spleen and vessels. So recently they have a liver surface nodulatory score which can detect presence of cirrhosis confidentially and correlate with HVPG. Advantage is that it can be implemented day-to-day practice and automatically it can be fit into the CT scan, so we can have that. So photosystemic collaterals we know are pathognomonic of this portal hypertension in cACLD and are associated with the higher HVPG and poorer outcome. And this CT scan can detect large esophageal varices quite accurately in 90% of cases. And when you use Doppler, those who are having portal vein low velocity, that is less than 12 centimeter, can have a consistent with presence of gastroesophageal varices. So there is another emerging method, contrast enhanced US is there, and this subharmonic aided pressure estimation that is safe has showed excellent correlation with invasive HVPG measurement, and it is 90% accurate for CHPS. So elastography for assessment of CHPS, it is a very good correlation between HVPG and liver stiffness measurement, which is excellent below threshold of 10. But above threshold of 10, there is poor correlation because not only liver fibrosis, that is the flow dependent increase in portal pressure, which is not reflected in LSM. Thus, a lot of meta-analysis which shows diagnostic capability of this method having good ECOROC score and sensitivity and specificity. So cutoff of 21 kilopascal to identify presence of CHPS demonstrated a high specificity, and Baveno 6 shows LSM greater than 20 to 25 can be used to identify this CHPS in patient with viral hepatitis induced cACLD. In Baveno 7, there is anticipate model which can detect 60% CHPS risks, and they have predicted LSM less than 15, platelet more than 1.5 lakhs, rule out CHPS. LSM 15 to 20 and platelet less than 1.1 lakhs, suggestive of CHPS. 20 to 25 LSM less than platelet 1.5 lakhs, suggestive of CHPS. And LSM alone more than 25 is suggestive of CHPS. This is the diagrammatic representation only. So drawback of this anticipate model is there are poor representation of NASH related CLD. That's why Pons and et al. They have developed this anticipate NASH model. We have included LSM, platelet and BMI, and up to 50% of patients with cACLD who show LSM less than 25 have CHPS. So there are combination algorithm are there where LSM less than 16, SSM less than 26 rule out CHPS with good sensitivity, LSM more than 38 rule in CHPS in all patients, and LSM less than 38, SSM more than 27 rule in CHPS with specificity of 91% in this study. So can elastography predict gastroesophageal varices? Transient elastography is the single best non-invasive method for varicose prediction. And this meta-analysis shows around good correlation between LSM and varices. And what is the role of spleen elastography? We know LSM can detect liver stiffness, but for portal hypertension, this when there is advanced stage, it less correlated. More than 10 HBPG is correlated less. However, SSM is a better correlator because SSM devoid some confounding factor of LSM, that is liver congestion, inflammation and infiltration, cholestasis. SSM take into account of dynamic component of portal hypertension, and SSM can differentiate cirrhotic and non-cirrhotic portal hypertension. So main disadvantage, there is a high failure rate, and in absence of splenomegaly, ascites, obesity, it is very difficult to measure SSM, and spleen is a stiffer organ than liver. So previously there is 75 kHz, but nowadays when there is splenic dedicated probe is there, so SSM at 100 Hz with value of 100 kilopascal can detect also. So there are good meta-analysis, and Baveno 7 also shown to rule out CHPS in viral hepatitis. If SSM is less than 21, we can rule out. If SSM is more than 50 kilopascal, we can rule out CHPS. So recent studies we show SSM and HBPG correlation decreases when HBPG is more than 16. So can spleen elastography can be used for assessment of gastroesophageal varices? Yes, lot of meta-analysis which show that good correlation between spleen SSM and gastroesophageal varices with good diagnostic accuracy and good ACURAC score. So in recent study they have shown prediction of large esophageal varices was improved with this novel spleen dedicated probe, and in this study they have used SSM at 100 Hz alone, and they have given a cutoff of 41.3 with 4.7% rate of missed high risk varices only. So it is acceptable, less than 5% only. So is there any Asian data? So this is Salimar group, as they have seen 641 NFLD patient from this center, and advanced fibrosis, they have around 1/4 have advanced fibrosis. They have assessed biomarkers, transient elastography and combination of this test, and they have shown in this study published in Digestive Disease Science where transient elastography perform better, highest accuracy. And they have suggested two-step strategy. NFS, first step NFS rule out criteria, and second step is LSM criteria. With that they correctly classify 62%, only 10.2% of participants incorrectly classified. This is our experience. My resident has published, this is presented this paper this year and EASL. And in our study, we have seen 156 patients in SSM was used to predict high risk varices, and it has a very good correlation and having high ACURAC value and better than LSM. And it is comparable with LSM plus platelet count plus SSM also. So we have given a cutoff of 35 kilopascal in Indian population and a very low miss rate, that is 3.8% only. And we have compared this with Baveno 6 and Baveno 7, and with high sensitivity and good specificity, we have a miss rate of 3.8%, whereas Baveno 7 has 11.3% in our cohort, whereas endoscopic spare rate, if you will see, we have 37%, whereas in Baveno 6 has only 16%. So in a nutshell, if key takeaway I will say, standard Baveno criteria, LSM less than 20, platelet more than 150. If it is there, no endoscopy can be spared. Expanded Baveno criteria, LSM less than 25, platelet count more than 110, we can spare the endoscopy. If it is no, endoscopy can be done. If you are taking SSM and Baveno 6, LSM less than 20, platelet count more than 150, and SSM less than 46, which can again spared endoscopy. LSM and SSM, LSM less than 12.5 kilopascal, SSM less than 41, we can spared endoscopy in that group also. So 707, variceal screening LSM, if it is more than 20 kilopascal or platelet less than 150, we can spared endoscopy in that group. So thank you for this opportunity. Thank you.